Imagine, for a moment, the sheer brilliance unfolding inside your body right now, completely unnoticed.
Yeah.
From the sting of a tiny paper cut to something far more serious, like an internal injury. Or even just the subtle wear and tear on your blood vessels from everyday life. There's an incredible, intricate emergency response system already built into your blood.
It's really quite amazing when you stop to think about it.
It's like a silent, microscopic ballet, perfectly choreographed to stop bleeding and initiate healing. But here's where it gets truly interesting. This very same system, designed to save you, can also malfunction,
Right, it can go wrong.
leading to dangerous, even life-threatening clots.
That's right. And for anyone who wants to grasp the real power and precision of human biology, I mean, to truly understand it like a seasoned professional, not just skim the surface, this system is absolutely foundational.
Welcome to the deep dive. Today we're plunging headfirst into the fundamental biological mechanisms of hemostasis and thrombosis.
Yeah.
Think of hemostasis as your body's vital stop-the-bleed operation, and thrombosis. That's when the system goes rogue, forming unwanted, dangerous clots.
Two sides of the same coin, in a way.
We're going to dissect this complex interplay with the kind of depth and clarity that connects all the dots, giving you those genuine aha moments.
Our guide for this deep dive is Harper's Illustrated Biochemistry, a truly authoritative resource. It really allows us to meticulously unpack the molecular symphony behind these vital functions.
Yeah, it's a great source.
And this isn't about memorizing every single detail, right? It's about seeing the elegant design, understanding the interdependencies, and gaining that professional level insight into why things work the way they do.
Exactly. Our mission is to uncover the intricate roles of platelets, those tiny dynamic cellular fragments, the complex web of coagulation proteins, and the delicate biological balance that determines whether our blood clots save lives or tragically threaten them.
It's a delicate balance indeed.
Get ready to rethink what you thought you knew about your own bloodstream.
Okay, let's do it.
So let's kick things off with the critical balance at the very heart of our discussion. Hemostasis versus thrombosis. Why should you even care about these two complex-sounding terms? What's the real-world impact?
You should care profoundly, really, because these two processes are directly linked to some of the leading causes of death worldwide.
That's a big statement.
It is. Let's start with hemostasis. At its core, this is your body's immediate, precise emergency response to stop bleeding from any cut or severed blood vessel.
Like first aid.
Exactly. Imagine your body has a team of tiny, efficient engineers ready to patch up a leak the instant it appears. It's absolutely protective, preventing you from bleeding out from even a minor injury.
So hemostasis is the good guy, the protector, and then there's thrombosis.
Precisely. Thrombosis is the formation of an unwanted clot, what we call a thrombus inside a blood vessel.
Where it shouldn't be.
Exactly where it shouldn't be. This typically occurs when the endothelium, that incredibly smooth, non-stick inner lining of your blood vessels, is damaged or removed. Think of it like a perfectly smooth pipe suddenly developing a rough patch where debris can snag and build up. A classic and extremely dangerous example is what happens following the rupture of an atherosclerotic plaque in an artery. That rough, exposed surface becomes a magnet for clot formation.
So if hemostasis is the body's vigilant guard, thrombosis is when that guard misfires, building a barrier where and when it absolutely shouldn't, like blocking the road unnecessarily.
You got it. While hemostasis is a vital, life-saving process that prevents hemorrhage, thrombosis represents a pathological malfunction. It's a critical breakdown in regulation where a clot forms inappropriately, obstructing blood flow and potentially leading to catastrophic consequences.
And the distinction matters clinically, right?
Oh, absolutely.
Yeah.
The distinction isn't just academic, it's crucial for understanding disease and how we manage it.
And this isn't just some abstract biological concept, is it? We're talking about immediate personal relevance.
Absolutely. The reason you should care deeply is because thromboses in the coronary arteries lead directly to heart attacks. And thromboses in the cerebral arteries lead to strokes.
Major killers.
Exactly. These events are not just medical curiosities. They are among the major causes of death globally. A clear and comprehensive understanding of these underlying biological processes is absolutely essential for grasping the rational management, the diagnosis, and the prevention of these widespread and devastating medical emergencies.
So for anyone aiming for that professional level of understanding,
It's foundational knowledge. You really have to get this to understand how the body works in health and disease.
that truly puts it into perspective. Now, what's genuinely fascinating is that despite their opposing outcomes, stopping bleeding versus forming an unwanted clot, hemostasis, and thrombosis, actually share three common phases.
Right, they use the same basic toolkit.
Almost like they're working from the same fundamental playbook. Let's really dig into these.
Indeed, both processes kick off with an immediate, almost instinctive response from the injured vessel itself, vasoconstriction.
The vessel clamps down.
Instantly. It's an instant narrowing of the blood vessel right at the injury site. Imagine a garden hose that's just been cut. Your body immediately cinches down the hose right near the cut.
Huh?
This significantly diminishes blood flow downstream from the injury, a crucial first step in reducing overall blood loss.
So the vessel constricts, buying time. What happens in phase 1, the first real construction phase?
Phase 1 is all about the formation of a loose, temporary platelet aggregate. Platelets are the body's first cellular responders here. Think of them as tiny, quick-response construction workers.
Okay, the little guys.
They swiftly bind to expose collagen at the site of vessel wall injury, collagen that's normally hidden.
Right, under the lining.
Exactly. This binding isn't passive. It triggers their activation, causing them to undergo dramatic changes. Two key actions immediately follow. First, they begin to produce thromboxane A2, or TXA2.
TXA2.
And second, they release a substance called ADP from their internal storage units, their granules.
And these aren't just random chemicals floating around, are they? They're like urgent distress signals.
Exactly. Powerful signals. Both TXA2 and ADP are potent signaling molecules. They act like chemical sirens, alerting and activating other platelets flowing by the injury site, effectively drawing them into the fray and amplifying the initial response.
So recruitment.
It's a rapid recruitment drive. And there's another key player that steps onto the scene right about now. Thrombin.
Ah, thrombin, the big enzyme.
While we'll discuss its formation in much more detail later within the coagulation cascade, it's critical to note that thrombin is also formed at this same site, and it causes further, incredibly potent platelet activation.
So it makes them even stickier.
Even stickier, even more responsive. It's a compounding effect, really ramping things up.
So once all these platelets are activated and recruited, what's the end result of this dynamic first phase? What have we built?
Once activated, platelets dramatically change shape. They become spiky and spread out, almost like they're trying to maximize their surface area to grab onto things.
Transform.
Right. And in the presence of key proteins like fibrinogen and/or von Willebrand factor, they aggregate tightly together. This aggregation forms either a hemostatic plug, in the case of normal bleeding control,
The good outcome.
or a thrombus, in the pathological context of unwanted clotting.
The bad outcome.
It's the body's initial quick fix patch, a temporary solution.
That's a great start. A loose plug forms. But a loose plug isn't going to hold up to the constant pressure of blood flow for long, right? It
No.
needs reinforcement.
Absolutely not. It's fragile. That brings us to phase 2.
Okay, phase 2.
Phase 2 is all about reinforcement. This is where a robust fibrin mesh is laid down. Imagine that initial platelet plug is a stack of sandbags.
Right.
The fibrin mesh is the concrete and steel rebar that gets poured over and around those sandbags, binding tightly to that initial loose platelet aggregate.
And the purpose of that, the big picture, why the mesh?
The purpose is to form a much more stable and durable hemostatic plug or thrombus. This fibrin mesh essentially locks the initial aggregate firmly in place.
Ah, makes it strong.
Provides the structural integrity needed to withstand the forces of blood flow and effectively seal the injury. It makes the patch permanent and strong.
Okay, so we've either stopped the bleeding effectively, or we've formed an unwanted clot that's now stable. But the body isn't just about forming things. It also has an incredible cleanup crew. What's phase 3?
Phase 3 is the body's sophisticated cleanup operation, the partial or complete dissolution of that hemostatic plug or thrombus.
Breaking it down.
Exactly. The key player here is plasmin, a powerful enzyme specifically designed to break down the fibrin mesh, the demolition expert.
So it's not just about forming clots, but also about dissolving them precisely when they're no longer needed or if they've formed inappropriately.
Exactly. This highlights the dynamic equilibrium of the system. Clots are formed as an emergency response, but they also need to be removed to restore normal blood flow and prevent long-term blockage.
Right, gotta reopen the road.
Plasmin ensures the vessel reopens, demonstrating that the body is constantly managing a delicate balance between clot formation and clot lysis, or breakdown. It's a continuous, intelligent, and finely tuned process, always adapting.
That's truly fascinating. So even though the end goals are different, stopping a leak versus a dangerous blockage, The fundamental phases are remarkably similar.
They share the core machinery.
Now, you mentioned a thrombus, that unwanted clot. Are all thrombi created equal, or are there different types that form under different circumstances? This seems important for that deeper understanding.
That's an excellent question, and a crucial distinction for anyone aiming for a professional understanding. Not all thrombi are identical.
Okay.
Their composition and the environment in which they form reveal crucial differences. What they all share, however, is the presence of fibrin, albeit in varying proportions.
Okay, let's unpack this. What's the first type we see?
The first type is the white thrombus. As its name suggests, it's primarily composed of platelets and fibrin with a relatively low number of red blood cells.
So it looks pale.
That's why it appears white, microscopically, yeah.
And where does this kind of clot typically form in the body?
The white thrombus typically forms at sites of injury or where the vessel wall is abnormal, and it's particularly characteristic of areas with rapid blood flow, such as arteries.
High speed, high pressure.
Exactly. Imagine the turbulent, high-pressure environment inside an artery. A classic example is the initial clot forming at the site of an atherosclerotic plaque rupture in a coronary artery.
Leading to a heart attack?
Often, yes. That's frequently a white thrombus. The high shear stress in arteries actually favors platelet aggregation as the primary event over red blood cell trapping.
Got it. So a white clot dominated by platelets in fast-moving arterial blood. What about the second type?
The second is the red thrombus. This type consists primarily of red blood cells and fibrin, giving it a macroscopic appearance very similar to a clot you might see formed in a test tube, dense and red.
So lots of red cells trapped inside.
Exactly.
And what kind of environment creates these? Where do they show up?
The red thrombus may form in vivo, meaning inside the body, in areas where blood flow is significantly retarded or stagnant.
Sluggish flow.
Right, a condition we call stasis. This is particularly common in veins, especially in the deep veins of the legs. It can form with or without initial vascular injury, or it can form as an extension of an initiating platelet plug at an injury site.
So deep vein thrombosis, DVT.
Exactly. If you're thinking about DVT in the legs, where blood flow can often be sluggish after long periods of immobility, that's typically a red thrombus. The slow flow allows red blood cells to get easily trapped within the growing fibrin mesh.
So red clots, dominated by red blood cells and fibrin, in slow-moving venous blood. And you mentioned a third type, perhaps less commonly discussed, but still significant.
Yes, the third type involves fibrin deposits in very small blood vessels or capillaries.
The microcirculation.
Right. While less talked about in the context of large vessel occlusion that causes heart attacks or strokes, this type underscores that clotting processes aren't just limited to major arteries and veins. They can also occur at the microvascular level.
And these can still cause problems.
Oh, definitely. These tiny microclots can significantly impact tissue perfusion, meaning blood flow to specific tissues, leading to localized tissue damage or organ dysfunction. Think of it like a traffic jam on the smallest back roads of your circulatory system.
It's clear that while we separate discussions of platelets and clotting factors for clarity, they are in reality performing incredibly intimate and often mutually interdependent roles in both hemostasis and thrombosis.
They absolutely are.
You can't truly understand one without understanding its deep connection to the other, can you? For that real mastery, you need to see the whole picture.
Exactly. The systems are deeply integrated, constantly influencing each other. Our breakdown is simply to facilitate a deeper understanding of the individual components before we integrate them back into the grand dynamic scheme.
Right. So let's now truly decode the intricate dance of platelet aggregation. You mentioned that platelets normally circulate as smooth, unstimulated, disc-shaped cells.
Like tiny inert frisbees floating along.
What makes them transform into these activated, spiky, clot-forming machines? How do they get the message?
That's where the magic, or rather the incredibly precise molecular biology happens. During hemostasis or thrombosis, these normally quiet platelets rapidly become activated.
Wake-up call.
Big time. They undergo dramatic changes to help form those plugs or thrombi we discussed.
And what are the three major steps involved in this transformation and activation? Let's break it down.
Okay, the first crucial step is adhesion. Platelets must first adhere to exposed collagen.
The damaged site?
Right, which becomes available when a blood vessel is damaged, like when the protective inner lining is breached. This adhesion is mediated by specific protein receptors on the platelet surface.
Like little hooks.
Exactly, including the glycoprotein complexes, GPII-DI and GPI-IXV, as well as GPVI. Think of them as molecular grappling hooks reaching out to grab onto the damaged wall.
Then what role does von Willebrand factor play here? I remember that being mentioned earlier as a key protein for forming the initial plug. Seems critical.
Excellent recall. Von Willebrand factor, or VWF, is absolutely crucial here. The binding of GPI-IXV to collagen is often mediated by VWF, particularly under conditions of high shear stress.
Fast looking.
Right. Imagine a river rapids. If a small boat needs to anchor, it needs a strong rope and a strong anchor. VWF acts like that strong rope, a molecular bridge,
Got it.
allowing platelets to grab onto the injured vessel wall even under intense turbulent blood flow, like what you find in small vessels and partially blocked arteries.
So they adhere, they hook on. What's the very next step after they've grabbed hold?
Once adherent to collagen, platelets dramatically change shape and spread out on the damaged subendothelium, almost flattening themselves against the wound.
Covering the area.
Exactly. This physical change triggers the second major step, release, or exocytosis, of the contents of their internal storage granules. They have two main types, dense granules and alpha granules.
And these granules are full of signals.
Full of signals. Many of the molecules released from these granules, such as ADP and serotonin, act as powerful amplifiers, signaling to and activating even more platelets, drawing them into the fray.
And thrombin, again, is a powerful stimulus for this release, creating a positive feedback loop, really pushing it forward.
Yes, thrombin, which is generated during the coagulation cascade, is a tremendously potent stimulator of this granule release. It creates a powerful positive feedback loop that accelerates platelet activation. It's like turning up the volume on the platelet activation signal.
Okay, so adhesion, then release of these amplifying signals. And finally, what's the third physical step?
The third step is aggregation. This is the process where activated platelets link together to form the growing plug. It's the actual physical accumulation of platelets, building on the initial adhesion and subsequent activation, creating that temporary barrier.
Now, for those of us who want to truly master this at a professional level, let's get into the nitty-gritty of the molecular signaling. How exactly do these external messengers translate into such dramatic changes within the platelet? What's the internal communication system like? This sounds complex.
This is where it gets truly fascinating and showcases the body's incredible engineering. It is complex, but elegant. First, there's outside-in transmembrane signaling.
Outside in. Okay.
Think of this as the platelet receiving an urgent message from the outside world, a stimulus or agonist, and then translating that message into internal instructions. The most potent activator of platelets, as we noted, is thrombin.
The main trigger.
It initiates this activation by interacting with its specific G-protein-coupled receptors on the platelet's outer membrane, specifically protease-activated receptor 1, PRR1, PR4, and also GPI-XV.
So thrombin is like the first critical key, unlocking a specific set of doors on the platelet surface. And then what? What's the internal signal cascade that follows? Where does the message go?
This key and lock interaction stimulates the activity of an intracellular enzyme called phospholipase CAR, or PLC.
PLC, got it.
Now, PLC is the central player. It acts like a molecular scissor, hydrolyzing a specific fat molecule embedded in the cell membrane called phosphodienoacetyl 4-heaven-5-bisphosphate, or PIP2.
PIP2, okay, cutting PIP2.
When PIP2 is cut, it forms two absolutely critical internal messenger molecules.
And those two messenger molecules are the ones that really kick off the internal changes, the downstream effects.
Exactly. The first is 102-diacylglycerol, or DAG.
DAG.
This molecule stimulates an important enzyme called protein kinase C, or PKC. PKC then phosphorylates a protein called plextrin. This phosphorylation is a key step, leading directly to that powerful platelet aggregation we discussed, and also to the further release of contents from those storage granules.
So DAG makes them sticky and prompts release.
Think of DAG as the signal that makes platelets stickier and dump their cargo, yeah?
And the second molecule from the PIP2 cut.
The second is 1,405-inositol trisphosphate, or IP3. IP3 is responsible for causing a rapid surge of calcium ions, Ca2+, into the cytosol, the main fluid of the cell.
Calcium burst.
Right, primarily from a storage compartment called the dense tubular system. This dramatic increase in internal calcium is a fundamental signal in many cells, including platelets.
What does the calcium do?
This calcium then interacts with other key proteins, leading to the phosphorylation of the light chains of myosin. And it's this myosin-actin interaction, this molecular muscle contraction, that drives the dramatic changes in platelet shape we observe during activation, those frisbees becoming spiky, spreading cells.
Wow. So from one external signal, thrombin hitting its receptor, we have two internal messengers, DAG and IP3. orchestrating both stickiness and shape change simultaneously.
It's highly integrated response, a true molecular symphony, very efficient.
But what about ADP and TXA2, the other activators you mentioned earlier?
Yeah.
How do they fit into this molecular puzzle and amplify the signal? They must use similar pathways.
Excellent question. They feed into the system. ADP, which is released from the dense granules of activated platelets, further activates other platelets via its own specific G protein-coupled receptors, namely P2Y1 and P2Y12.
So ADP calls its buddies using P2Y receptors.
Pretty much. This creates a powerful positive feedback loop, drawing even more platelets into the growing aggregate. It's like a chain reaction of activation.
And the thromboxane A2 loop, how does that amplify the signal even more? That sounds important.
The thromboxane A2 loop is another critical amplification step. When collagen activates a platelet, the increased intracellular calcium causes a platelet cytosolic phospholipase A2, or CPLA2, to liberate arachidonic acid from the platelet's membrane.
Okay, frees up arachidonic acid.
This arachidonic acid is then converted into thromboxane A2, TXA2. In turn, TXA2 binds to its specific G protein-coupled receptor, TP, which further activates PLC.
The same enzyme thrombin used.
The very same one, thus promoting even more platelet aggregation. It's a self-sustaining cycle, designed to rapidly escalate the response to injury.
So that's the outside in and signaling, getting the platelet activated and signaling to others. But how do activated platelets actually stick to each other to form that cohesive aggregate? What's the inside-out part of the process? How do they grab onto their neighbors?
That's the inside-out signaling pathway, and it's absolutely crucial for forming a stable aggregate. All the aggregating agents we've discussed, thrombin, collagen, ADP, TXA2, and even others like platelet activating factor, initiate this internal pathway.
So it's a common response to activation.
Yes. This pathway modifies a specific platelet surface protein complex called GPII bifida, also known as IB3 integrin.
GPI bifida, what kind of modification happens? It sounds like a molecular switch.
Precisely. This modification transforms GPI bifida from its resting low affinity state to an activated form that has a much, much higher affinity for fibrinogen or von Willebrand factor.
Makes it super sticky for those molecules.
Like a sticky molecular handshake that suddenly becomes a vice-like grip. Molecules of divalent fibrinogen, or the larger multivalent von Willebrand factor, then act as molecular bridges, literally linking adjacent activated platelets to each other.
So fibrinogen or VWF are the actual bridges between platelets.
That's how that cohesive platelet aggregate forms. It's important to remember that VWF-mediated aggregation is especially crucial under conditions of high shear stress, like those found in small, rapidly flowing vessels, where strong adhesion is paramount.
And other agents like epinephrine, serotonin, and vasopressin can exert synergistic effects here, enhancing the action of other aggregating agents, right? They don't directly cause aggregation, but boost its efficiency. They're like helpers.
Exactly. They act as molecular cheerleaders, fine-tuning and boosting the overall platelet response, ensuring the system responds robustly when needed.
So beyond just forming a sticky mass, do activated platelets play any other roles in actually building the larger, more stable clot, the fibrin scaffold? Do they help the next stage?
Absolutely, and this is critical to understanding their orchestrating role, especially for that professional level view. Activated platelets act as significant procoagulants.
Procoagulants, meaning they promote coagulation.
Yes. Beyond forming the physical aggregate, they play a crucial role in accelerating the activation of coagulation factor X and prothrombin.
How do they do that?
They achieve this by exposing a specific negatively charged fat molecule called phosphatidylserine on their membrane surface. This normally hidden lipid flips to the outside upon activation.
Okay.
This provides a critical, negatively charged platform for the assembly of key coagulation factor complexes, dramatically speeding up those reactions. Think of it as providing the perfect stage, the right chemical environment, for the next act of the clotting drama.
And there's also polyphosphate involved, isn't there? Released from those granules, adding another layer.
Yes. Polyphosphate, also released from those dense granules we mentioned, further accelerates factor V activation and factor XI activation by thrombin. This multifaceted involvement highlights how platelets are not merely passive participants that just stick together. They are active orchestrators, providing both the cellular aggregate and the crucial catalytic surface for the entire hemostatic and thrombotic process.
So much going on.
It's a beautifully coordinated, highly intelligent effort, working at multiple levels simultaneously.
That's an incredible level of detail, truly showing the complexity involved. But while platelets are central, they don't operate in a vacuum. What about the endothelial cells lining our blood vessels? Do they have a role too, perhaps, in keeping things from clotting too much, the checks and balances?
They absolutely do. Endothelial cells are often the unsung heroes, the vital regulators of clotting. They make crucial contributions to the overall regulation of hemostasis and thrombosis by providing a vital anticoagulant counterbalance.
Fighting against the clot.
Essentially, yes. They work tirelessly to maintain the fluidity of blood and prevent inappropriate clot formation, essentially acting as the body's internal peacekeepers, constantly reminding the blood not to clot unless absolutely necessary.
So they're the guardians of blood flow, working to prevent unwanted stickiness. What are some of their key contributions to this crucial anticoagulant environment? How do they keep things calm?
One major contribution is the synthesis of prostacyclin, or PGI2. Endothelial cells continuously release this prostanoid, which is a potent inhibitor of platelet aggregation.
A don't stick signal.
Like a constant don't stick signal, exactly.
And how does prostacyclin achieve that molecularly? How does it tell platelets to relax?
Prostacyclin acts by stimulating the activity of an enzyme called adenyl cyclase in the surface membranes of platelets via its G protein-coupled receptor. The resulting increase in intraplatelet cyclic AMP or KMP
okay.
directly opposes the increase in the level of intracellular calcium, T2 plus ISA, which is produced by IP3 during activation.
So it counters the calcium surge.
By essentially calming that critical calcium surge, it effectively inhibits platelet activation. This is in direct contrast, as you can see, with the effect of thromboxane A2 TXA2 that is formed by activated platelets, which promotes aggregation.
The push.
This is a perfect, elegant example of the precise push-pull balance in the system, where one signal encourages and another discourages the same action, essential for control.
So PGI2 from the endothelial cells puts the brakes on platelet aggregation, while TXA2 from platelets hits the gas. What else do these remarkable endothelial cells do to keep things flowing smoothly?
They also possess a surface-expressed enzyme called ectoatase, which directly hydrolyzes ADP.
Breaks down ADP.
Yes. Remember, ADP is a powerful platelet activator released by platelets. By breaking down ADP in the immediate vicinity, it directly opposes ADP's powerful aggregating effect on platelets.
Cleaning up the signal.
Exactly. Furthermore, these cells express specialized sugar protein molecules called proteoglycans, like heparin sulfate, which acts as a natural anticoagulant on their surface, like a non-stick coating.
And they play a role in dissolving clots too, right? Not just preventing them.
Yes. Endothelial cells also release plasminogen activators, which play a crucial role in helping to dissolve thrombi, a topic we'll explore in detail later. And let's not forget nitric oxide, also known as endothelium-derived relaxing factor.
Nitric oxide, the gas.
Yes, that one. This is another potent platelet inhibitor released by endothelial cells, contributing to both vasodilation widening the blood vessels and antiplatelet activity.
So it relaxes the vessel and the platelets?
It's like a multitasker, ensuring smooth flow and preventing stickiness.
So it's fair to say the endothelium acts as a vital guardian, constantly monitoring the situation, much more than just a passive lining.
Precisely. It acts as a vigilant guardian, constantly maintaining the fluidity of blood and preventing inappropriate clot formation through a diverse array of secreted molecules and surface-expressed components. It's a dynamic, active interface, a crucial biological checkpoint between the flowing blood and the vessel wall. Absolutely critical for homeostasis.
Here's where it gets really interesting, the practical application. Understanding all this intricate platelet biology isn't just for textbooks. It allows for targeted pharmacological interventions.
Right, the medicine.
We're talking about antiplatelet drugs designed to inhibit platelet responses and prevent unwanted, dangerous clotting. Let's start with the most famous one, the one probably in your medicine cabinet.
Without a doubt, that's aspirin or acetylsalicylic acid. It's the most widely used antiplatelet drug globally. Truly a medical marvel for its simplicity and effectiveness.
Simple but powerful. How does it work? What's its mechanism?
Its mechanism of action is quite elegant. Aspirin irreversibly modifies and thereby inhibits platelet cyclooxygenase, specifically TOX1.
TOX1.
That's the enzyme directly involved in the formation of PKXA2, that pro-aggregation signal we keep mentioning.
And since TKXA2 is a potent aggregator and vasoconstrictor, hit the gas signal for platelets, inhibiting its formation effectively puts the brakes on platelet activity. But what's truly remarkable is how little aspirin it takes to do this, isn't it?
It truly is a testament to the specificity of the drug. Platelets are remarkably sensitive to aspirin. As little as 30 milligrams of aspirin per day, which is a tiny fraction compared to a regular tablet containing 325 milligrams, is sufficient to effectively eliminate the synthesis of TXA2 by platelets.
Wow, that's potent.
It's like a molecular precision strike, very effective at low doses for this purpose.
But doesn't aspirin also inhibit the good guys, like prostacyclin, PGI2 from the endothelial cells, which prevents clotting? How does the body compensate for that so aspirin still has its overall anti-clotting effect? That seems like a contradiction.
That's a critical, subtle point and key to understanding why it works. While aspirin does inhibit the production of PGI2 by endothelial cells, which normally poses platelet aggregation, there's a key difference between platelets and endothelial cells.
What's the difference?
Endothelial cells are complete cells. They have a nucleus. They can make new proteins. They regenerate new COX-1 enzymes within a few hours after aspirin inhibits them.
Okay, they recover.
Platelets, however, are essentially fragments of cells. They lack a nucleus. They cannot synthesize new COX-1 once it's inhibited by aspirin. The effect is permanent for the life of that platelet.
Ah, so the platelet is knocked out for good, but the endothelium recovers.
Exactly. Therefore, over time, the overall balance between TXA2, the pro-clotting signal from platelets, and PGI2, the anti-clotting signal from endothelium, is shifted decisively in favor of PGI2.
Favoring the anti-clotting side.
Right, thus opposing platelet aggregation in the long term. This differential regeneration is a crucial aspect of aspirin's sustained antiplatelet effect. It's quite clever biologically.
So it's a clever biological workaround that makes aspirin effective. And the clinical indications for aspirin are quite broad, aren't they, covering many common serious conditions?
They are. Aspirin is a cornerstone in the management and prevention of various atherothrombotic diseases, those conditions where clots form on hardened arteries. This includes acute coronary syndromes like angina and myocardial infarction, acute stroke syndromes such as transient ischemic attacks and acute stroke, and severe carotid artery stenosis. It's also widely used for the primary prevention of these conditions in individuals deemed to be at high risk.
So, really important drug. Beyond aspirin, what other classes of antiplatelet drugs do we have targeting different steps in the platelet activation cascade, if aspirin isn't enough or suitable?
We have several, each offering a different point of attack, which is great for tailored therapy. One important class consists of specific inhibitors of the P2Y12 receptor for ADP.
That ADP receptor we talked about.
Exactly, the one that ADP uses to amplify the platelet response. Examples include clopidogrel, prasugrel, ticagrelor, and cangrelor. By blocking this receptor, they effectively prevent ADP-mediated platelet activation and aggregation.
Cutting off that specific communication line.
Precisely. It's like cutting off one of the main communication lines for platelets.
And what about targeting thrombin's effect on platelets directly, since thrombin is so potent?
For that, we have antagonists of the thrombin receptor PR1, with Vorapaxar being an example. By blocking thrombin's ability to activate platelets via this specific receptor, it reduces their pro-aggregatory response.
Another way to dial down the stickiness signal.
Yes, targeting the most potent activator.
And finally, the common pathway of aggregation itself, that GPIA-FIA complex that acts like the final molecular handshake between platelets. Can we block that?
Yes, we can. We have antagonists of ligand binding to GPI-PAGI. Examples include abciximab, eptifibatide, and tyrofluben.
How do they work?
These drugs directly interfere with the binding of fibrinogen and von Willebrand factor to the activated GPI-IDA complex.
So they stop the bridging molecules from linking platelets.
Exactly, thereby inhibiting the final common pathway of platelet aggregation, literally preventing platelets from linking arms and forming a cohesive clot. It's a very powerful mechanism.
So what does this all mean when you look at the big picture of drug development? This diversity of drugs really highlights the multifaceted nature of platelet activation.
It really does.
Allowing for incredibly tailored therapeutic strategies based on which specific pathways you need to target. It's an elegant example of biochemical understanding leading directly to clinical solutions.
It absolutely does. Understanding these intricate pathways allows clinicians to choose the most appropriate drug or combination of drugs to prevent or treat thrombotic conditions, optimizing efficacy while minimizing bleeding risks. It's a direct application of biochemical mastery to patient care.
Now, let's move beyond the platelet plug and onto the core of the clot itself, the fibrin scaffold. We're talking about the coagulation pathways.
Right, the cascade.
Historically, two major pathways, the extrinsic and the intrinsic, have been described, both leading to the formation of a fibrin clot. While in the body, they're deeply interconnected. We'll discuss them separately to build our understanding, but always remember their synergy. The separation is mostly for teaching, right?
Yes, largely for clarity. In reality, they talk to each other constantly. But let's start by categorizing the players. The proteins involved in blood coagulation, these molecular players, can be broadly categorized into 5 types.
Okay, 5 types.
First, we have the zymogens of serine-dependent proteases. Think of these as dormant enzymes, essentially scissors that are initially closed, waiting for a very specific signal. A precise molecular cut to spring into action, and then, in turn, make their own specific cuts.
The cutters. Examples?
Examples include factors 12, 11, 9, 9X, and prothrombin, which is also called factor 2.
And then there are the cofactors. What do they do?
Yes, the second type are cofactors. These are proteins that don't do the cutting themselves, but dramatically enhance the activity of the activated proteases, making them much, much more efficient. They're like organizers or platforms.
Got it. Examples.
Examples include factors V8 and tissue factor, or factor 3. Thirdly, we have fibrinogen, which is factor 1, the direct raw material, the substrate for thrombin that forms the fibrin clot itself.
The building block.
Exactly.
And a very specialized enzyme, factor 13. You mentioned it briefly.
That's the 4th category. A zymogen of a transglutaminase, factor 13. This enzyme, once activated, is like the molecular superglue, covalently cross-linking fibrin to stabilize the clot, a critical step for its durability and strength. We'll come back to that.
Okay. And the 5th category?
And finally, the 5th category includes regulatory and other proteins. These act as the system's checks and balances, controlling or modulating the entire coagulation process.
Like the brakes in controllers.
Precisely. Examples include protein C, protein S, and thrombomodulin.
Okay, let's dive into the extrinsic pathway first. This is the pathway that really gets the clot started in response to an actual injury, right? The initiator.
Yeah.
How does it initiate that precise cascade?
The extrinsic pathway is indeed primarily responsible for initiating fibrin clot formation in response to actual tissue injury. It begins with the rapid exposure of tissue factor, or TF.
Tissue factor, where does that come from?
TF is a glycoprotein normally hidden away in the subendothelium, meaning outside the blood vessel lumen in the surrounding tissue, and also found on certain activated immune cells like monocytes. So when there's damage, TF becomes visible to the blood.
So injury exposes tissue factor, like pulling a tripwire? And then what happens? What does TF grab onto?
TF immediately interacts with and activates factor 7, an inactive precursor protein, a zymogen.
Factor 7?
Importantly, factor 7, along with factors 2, NiX, and X, contains special vitamin K-dependent modified amino acids called gamma-carboxyglutamate, or GLA residues.
GLA residues. Why are they important?
These GLA residues are absolutely crucial because they allow these factors to bind tightly to calcium ions and to the negatively charged surfaces of activated cells like platelets. This binding is essential for their proper function in the coagulation pathways. Factor 7 is synthesized in the liver.
And then factor A, once activated, forms a crucial complex with tissue factor.
Precisely. Tissue factor acts as a crucial cofactor for factor A, significantly enhancing its enzymatic activity. This complex, composed of calcium, tissue factor, and factor A, is known as the extrinsic tenese complex.
Tenese because it activates factor 10.
Exactly. It assembles on a cell membrane surface that exposes the procoagulant anionic aminophospholipid phosphatidylserine, which, as we noted earlier, is found on the surface of activated platelets. It's like setting up a molecular workstation on the platelet surface.
And this extrinsic tenese complex then activates factor X, moving us closer to the final clot.
Yes. Factor A, working within this complex, makes a specific molecular cut in factor X to produce the active 2-chain serine protease, factors A.
Factors A, a key player.
A very key player. What's also important, and highlights the interconnectedness you mentioned, is that TF and factor A can actually activate factor IX in the intrinsic pathway as well.
Crosstalk between the pathways.
Demonstrating how these pathways aren't entirely separate in the living body.
So in real life, in vivo, this TF factor 8 complex is now considered the key process involved in the initiation of blood coagulation. This is where it starts.
It absolutely is the primary trigger for initiation in response to injury. And the body also has a remarkably clever natural inhibitor for this pathway, a built-in brake.
What's that called?
Tissue factor pathway inhibitor, or TFPI. TFPI circulates in the blood and directly inhibits factor AC by binding near its active site.
Stops factor beta.
Right. And then this factor's A-TFPI complex then in turn, acts as a brake on the factor ETF complex, the initiator complex,
So it shuts down both the zeta and the thing that made it.
providing a crucial feedback loop to prevent excessive clotting right at the very start. It's an elegant braking mechanism to keep initiation in check.
So that's the extrinsic pathway, the swift initiator responding to tissue damage. Now let's shift to the intrinsic pathway. How does it amplify the signal, and what are its components? Seems more complex.
The formation of factor DIRA is indeed the major convergence point, where the intrinsic and extrinsic pathways both funnel their activity. The intrinsic pathway involves factors 12, 11, 9, 8, and X,
A lot more factors.
along with several other key players like prekallikrein, high molecular weight, or HMW, kinagen, calcium ions, and cell surface exposed phosphatidylserine. This pathway ultimately leads to the production of factor DIRA by what we call the intrinsic tenese complex.
And another tenese complex.
Yes, but this one uses factor IXA as the active enzyme and factor ACA as its crucial cofactor. Different players, same goal, activate factor X.
And how is this pathway initiated? I've heard it called contact activation. Is it just about blood touching anything outside the vessel? What kind of surface?
Yes, the intrinsic pathway can be initiated by contact, where prekallikrein, HMW kinagen, and factors 12 in the eye are exposed to a negatively charged activating surface.
Negatively charged, like what? In the body.
In the body, certain macromolecules like polymers of phosphates, extracellular DNA, RNA, and polyphosphate molecules that are only available after significant cell damage or rupture may serve as this negatively charged activating surface. In laboratory tests, a substance called kaolin, a highly negatively charged mineral, is commonly used to activate it.
So it's about an abnormal surface triggering the cascade.
Exactly.
And once contact is made, what's the detailed cascade of steps here? The domino effect for the intrinsic pathway.
When these components of the contact phase assemble on the activating surface, factor 12 is activated to factor 12 upon proteolysis by kallikrein.
Okay, 12 becomes 3.
This newly generated factor 3 then turns around and cleaves prekallikrein to produce more kallikrein, setting up a potent positive feedback activation loop that rapidly amplifies the signal right at the start.
Amplification loop, got it.
Factor 2A, once formed, also activates factor 11 to factor 3. Furthermore, factor 12 also releases bradykinin, a peptide with potent vasodilator action from H&W kinagen.
So it affects vessel turn too. And then factor A activates factor IX, leading eventually to factor A.
Correct. Factor A, in the presence of calcium, activates factor IX, another glycan-containing inactive precursor to the active enzyme, factor ISA. Factor ISA then makes a specific cut in factor X to produce factor A.
Using that intrinsic tenese complex.
Exactly. This latter reaction, the production of factor T, requires the precise assembly of the intrinsic tenese complex, composed of calcium, factor A, and factor ISA. This complex forms on procoagulant membrane surfaces, often on activated platelets, that are now exposing that crucial phosphatidylserine we discussed.
The platelet surface again, very important.
Crucial platform. Remember, this phospholipid is normally hidden on the inner leaflet of resting platelets, but flips to the outer surface upon activation.
And factor VIII plays a critical role as a cofactor here, but it's not a protease itself, right? It's more of an organizer. This seems key for mastery.
That's a crucial distinction for mastery. Factor VIII, a large circulating glycoprotein, is not a protease precursor. It doesn't cut anything. Instead, it's a cofactor precursor.
What does it do then?
When activated by even minute quantities of thrombin to factor VIII, it serves as a receptor or platform on the platelet surface, effectively bringing factors IGZA and X together in the optimal orientation to dramatically speed up the factor zeta production.
Organizes the reaction.
Precisely. Factor eta is subsequently inactivated by further cleavage by thrombin-mediated activated proteins D, providing a built-in off switch to prevent overactivation, another control point.
What's truly fascinating here is that the role of the initial steps of the intrinsic pathway in initiating coagulation has been called into question. Why is that? It sounds counterintuitive if it's part of the clotting cascade. Why question factor 12?
It is a profound insight and really changed thinking. The reason for this reevaluation is quite striking. Patients with hereditary deficiencies of factor 12, prekallikrein, or HMW kinagen often do not exhibit bleeding problems in real life.
They're missing parts of the pathway but don't bleed.
Exactly. Similarly, patients with a factor Xa deficiency may not have significant bleeding issues. Their intrinsic pathway is impaired, yet they don't bleed extensively. In fact, oddly enough, deficiencies in the intrinsic pathway, particularly in factor Xa, can even be protective against thrombosis.
Less likely to clot abnormally.
Right, they're less likely to form unwanted clots.
So if it's not primarily for initiating coagulation in response to injury, what's the intrinsic pathway's main function then in the grand scheme of blood clotting? Why have it?
Its primary function now appears to be to amplify factor SAA and ultimately thrombin formation through those crucial feedback mechanisms we discussed, particularly the activation of factor AX by thrombin and the activation of factor XE by thrombin.
So it's a booster, not the initial spark.
It ensures a robust and sustained clot once the process has begun, triggered by the extrinsic pathway. It may also play a role in fibrinolysis, the clot-dissolving process, as kallikrein, and factors 3 and SHIA can actually cleave plasminogen, and kallikrein can activate single-chain urokinase. So it might have roles on both sides of the balance.
Complex interactions. Okay, so the extrinsic pathway initiates, the intrinsic pathway amplifies, and both converge at factor JAD. This leads us to the common pathway, the central hub, where factor ZA converts prothrombin to thrombin. How does that crucial step happen, the ultimate conversion to the master enzyme?
Factor ZA, regardless of whether it's produced by the extrinsic or intrinsic pathway, is the direct activator of prothrombin, or factor 2 to thrombin, factor
The big
conversion, right?
Yep.
Like factor X activation, the activation of prothrombin occurred on a procoagulant membrane surface and requires the precise assembly of what we call a prothrombinase complex.
Prothrombinase. Activating prothrombin makes sense. And what are the key players in that complex?
This complex consists of calcium, factor VA, and factor ZA. Its assembly also takes place on the phosphatidylserine-exposing membrane surface, which, as we've highlighted, is often provided by activated platelets.
That platelet surface is really the central hub.
It's the critical workbench for these reactions.
So factor V is another cofactor, similar to factor VIII in the Tenese complex, organizing the reaction for prothrombin activation.
Precisely. Factor V, a large protein synthesized in the liver, spleen, and kidney, and found in both platelets and plasma, is activated to factor VA by even tiny traces of thrombin, another amplification loop.
Thrombin activates its own activator's cofactor.
Yes. Factor VA then functions as a cofactor in the prothrombinase complex. It binds specifically to a procoagulant membrane, again, typically activated platelets, and forms a complex with factors A and prothrombin, positioning them perfectly. Crucially, factor VA is subsequently inactivated by activated protein C.
Protein C again.
Providing yet another crucial mechanism for limiting thrombin activation, another built-in off switch.
And what about prothrombin itself, the inactive precursor, factor 2?
Prothrombin, a single-chain glycoprotein synthesized in the liver, is the inactive precursor. Its amino-terminal region contains 10 glass residues.
Those vitamin K-dependent ones?
Vital for its calcium-binding function, anchoring it to that specialized membrane surface. The active serine protease site, the part that actually does the cutting, is in its catalytic domain near the other end of the molecule.
How does factor ZAC cut it?
Upon binding to the factor VA and ZAC complex on the procoagulant membrane, prothrombin is cleaved by factor ZAG at two specific sites. This generates the active two-chain thrombin molecule. This newly formed thrombin is then released from the membrane surface, ready to do its powerful work throughout the blood.
And thrombin's most famous job is converting fibrinogen to fibrin, building that stable clot scaffold. How does that final crucial step happen, building the actual structure?
Thrombin's pivotal role extends beyond just activating platelets and factors V and VIII. It truly is the master enzyme. It is the enzyme that converts soluble fibrinogen into insoluble fibrin,
The mesh material.
forming the core structural component of the clot. Fibrinogen, or factor I, is an abundant soluble plasma glycoprotein. It's a dimer of 3 polypeptide chains, and a big O2.
Complex structure.
Like 2 sets of triple braided ropes, covalently linked by 29 disulfide bonds. This gives it a characteristic trinodular elongated structure with the central E domain linked to 2 lateral D domains via coiled coil regions.
And the fibrinopeptides, FPA and FPB, what's their role? Do they get cut off? You mentioned them keeping fibrinogen soluble.
Yes, exactly. The N-terminal A and B portions of the anode and base chains are called fibrinopeptide A, FPA, and fibrinopeptide B, FPB, respectively. These domains are highly negatively charged due to an abundance of aspartate and glutamate residues.
Negative charge keeps them apart.
Right. This negative charge is crucial for fibrinogen solubility in plasma and, importantly, prevents premature aggregation by causing electrostatic repulsion between fibrinogen molecules. They act like a molecular non-stick coating, ensuring fibrinogen remains soluble until needed.
So thrombin cleaves these non-stick fibrinopeptides off, allowing the fibrin to polymerize.
Precisely. Thrombin, the serine protease, hydrolyzes 4 specific Arglay bonds, literally cutting between the N-terminal fibrinopeptides and the main UNI and board portions of the fibrinogen chains. The release of FPA and FDB generates what we call fibrin monomer.
Fibrin monomer, ready to link up.
Right, which now has exposed sticky ends. Since FPA and FDB are relatively small, the fibrin molecule retains 98% of the residues present in fibrinogen. It's largely intact, but now capable of assembly.
And then these fibrin monomers spontaneously polymerize. It sounds like they just naturally link up once those inhibitory peptides are gone. No enzyme needed for this part.
That's right, spontaneous polymerization. The removal of the fibrinopeptides exposes new binding sites within the central E domain of fibrin monomers. These sites specifically interact with complementary domains within the D domains of other fibrin monomers.
E binds to D.
Exactly. This leads to the spontaneous polymerization of fibrin monomers in a half-staggered, highly ordered pattern, forming long strands called protofibrils. While insoluble, this initial fibrin clot is still relatively unstable, held together only by the non-covalent association of these monomers. Reinforcement.
That sounds like it needs further stabilization, like a final reinforcement. That's where factor XIII comes in, right? The molecular superglue?
Absolutely. The final touch for strength. In addition to converting fibrinogen to fibrin, thrombin also activates factor XIII to factor XIII. Factor XIII is a highly specific enzyme called a transglutaminase.
Transglutaminase, what does it do?
Its crucial role is to covalently cross-link the gamma chains and, more slowly, the alpha chains of fibrin molecules. It achieves this by forming strong, permanent peptide bonds between specific glutamine and lysine residues from adjacent fibrin molecules.
Literally weaving them together with chemical bonds.
Exactly, like stitching the bricks together with mortar.
So it's essentially cementing the clot, making it incredibly tough.
Exactly. Such cross-linking yields a much more stable fibrin clot with significantly increased resistance to proteolysis, meaning it's much harder for other enzymes to break it down. This robust fibrin mesh serves to permanently stabilize the hemostatic plug or thrombus, ensuring it forms a durable, unyielding seal.
So what does this all mean for us? We've gone from a single injury signal triggering an immediate platelet response to this incredibly complex multi-protein cascade culminating in a stable, cross-linked fibrin clot, the ultimate scaffold that seals the wound.
It's quite a journey.
It's truly an incredible process, operating with such precision and interconnectedness. Understanding all these steps seems vital for that mastery.
It is, and the depth of understanding required to appreciate each component's precise role, from the molecular interactions to the larger protein complexes, is what allows one to truly master this field. It's a testament to the elegant solutions nature has developed over millennia.
Given how powerful and potentially dangerous thrombin is, it's like the master switch for clotting. Once it's formed, its concentration must be meticulously controlled.
Absolutely crucial.
To prevent runaway fibrin formation or excessive platelet activation. How does the body achieve this incredibly delicate balance? It can't just keep clotting forever. What are the breaks?
The body has evolved highly sophisticated mechanisms to prevent a runaway reaction. There are two primary control mechanisms. First, there's the inherent cascade regulation and amplification itself.
How does the cascade regulate itself?
Well, thrombin circulates as its inactive precursor, prothrombin, which is only activated as a consequence of that precise cascade of enzymatic reactions we just walked through. Each step converts an inactive zymogen to an active enzyme, leading finally to thrombin.
So it's a precisely controlled release system, not just a free-for-all.
Exactly. It requires multiple specific steps to happen in sequence. At each point in this cascade, complex feedback mechanisms ensure a delicate balance of activation and inhibition. Furthermore, the clotting cascade provides enormous amplification.
Amplification can be dangerous, though.
It can, but it's also necessary for a rapid response. For example, the concentration of factor XII in plasma is roughly 30 micrograms per milliliter, while that of fibrinogen, the final product, is 1,000 times higher, at 3 milligrams per milliliter, with intermediate clotting factors progressively increasing in concentration down the cascade. This demonstrates how a small initial signal can be massively amplified into a robust, but still ultimately controlled response.
And the second primary control mechanism after the cascade itself is what? Direct inhibitors.
Yes. The second crucial means of controlling thrombin activity is the rapid inactivation of any formed thrombin by naturally occurring circulating inhibitors. The most important of these, the real heavyweight, is antithrombin.
Antithrombin. What makes antithrombin so important and broad-reaching in its effects? Does it just stop thrombin?
It's the main one, contributing approximately 75% of the total antithrombin activity in normal plasma. But it's not just a thrombin inhibitor. It has broad inhibition capabilities.
What else does it hit?
It can also inhibit the activities of other key activated coagulation factors, including factor ISA, factor ZIAs, factor ZIA, factor 3A, and even factor IA when it's complexed with tissue factor.
Wow, it takes out a lot of the key enzymes.
It's like a molecular bouncer, clearing out several active players to calm things down.
And its activity is dramatically boosted by something in our body, which we also use as a drug, right? This is where the biology connects directly to medicine again. Heparin.
Yes, exactly.
Yeah.
Heparin and related molecules called heparins. Its endogenous activity is dramatically potentiated by the presence of these sulfated sugar protein molecules called heparins, which are found on endothelial cells.
How do they boost it?
These heparins bind to a specific positively charged site on antithrombin, which induces a conformational change, essentially reshaping it. This conformational change is key because it promotes the binding of antithrombin to thrombin and factors A, as well as to its other targets, greatly accelerating their inactivation.
Makes antithrombin much faster and better.
Greatly accelerates it. It's like a chemical shortcut to making antithrombin super efficient.
And this precise mechanism is why heparin is such an important clinical tool, a cornerstone of anticoagulant therapy.
Absolutely. This precise mechanism is the very basis for the widespread clinical use of heparin, a derivatized heparin, to inhibit coagulation.
Can you reverse heparin if needed?
Yes, the anticoagulant effects of heparin can be antagonized or reversed by strongly positively charged polypeptides like protamine. Protamine binds strongly to heparin, thereby preventing heparin's ability to bind to antithrombin, effectively turning off its action almost instantly.
And now we have low molecular weight heparins, or LMWHs, which are used even more frequently. Why are they preferred sometimes?
Yes, LMWHs derived from the enzymatic or chemical cleavage of unfractionated heparin are more commonly used clinically due to several advantages. They can be administered subcutaneously at home.
Easier for patients.
Much easier. They also have greater bioavailability than unfractionated heparin, meaning more of the drug gets to where it needs to go predictably, and typically do not require frequent laboratory monitoring, simplifying patient management significantly compared to unfractionated heparin.
What happens if someone has a genetic deficiency in antithrombin? What's the real-world consequence? Does it prove how important it is?
Absolutely proves it. Individuals with inherited deficiencies of antithrombin are prone to developing venous thrombosis. They clot too easily.
So it's essential.
This provides strong evidence that antithrombin has a critical physiological function, and that the coagulation system in humans is normally maintained in a dynamic, finely balanced state. Even a slight imbalance in the system can have serious consequences, highlighting how precious that equilibrium is.
Are there other inhibitors besides antithrombin?
Yes, other inhibitors like beta-2-macroglobulin, heparin cofactor 2, and AD1 antitrypsin contribute to the remaining antithrombin activity, though to a lesser extent under normal physiological conditions.
And thrombin itself is involved in another crucial regulatory mechanism, isn't it? The protein CS system, another elegant feedback loop involving the endothelium.
It is. This is another example of the body's self-regulating genius, turning the product, thrombin, into part of the control system. Thrombin, once formed, combines with thrombomodulin.
Thrombomodulin, where is that?
Thrombomodulin is a glycoprotein present on the surfaces of healthy endothelial cells. This complex of thrombin and thrombomodulin then activates protein C, which is an inactive precursor, on the endothelial protein C receptor.
Okay, activates protein C.
Converting it into activated protein C, or AP, which is another serine protease.
And what does APC do? How does it help put the brakes on clotting? It's another inhibitor.
Yes, effectively. In combination with protein S, which acts as a cofactor, and importantly, both protein C and protein S contain those crucial GLIDA residues we discussed.
Vitamin K dependent again?
Right. AKC specifically degrades activated factors VA and HIA.
Takes out the cofactors.
Exactly. By degrading these critical cofactors, these molecular organizers for the tenese and prothrombinase complexes, ATC effectively limits their actions in coagulation, thus dampening the clotting cascade.
Like pulling the plug on the amplification stage of the reaction? Very clever.
A very important negative feedback loop to prevent excessive clotting.
And if the system isn't working properly because of a genetic flaw, for example, problems with protein C or S
A genetic deficiency of either protein C or protein S can cause venous thrombosis, again highlighting their vital protective roles. They clot too much if these are missing or low.
And factor V Leiden, that's related to this, right?
Yes, very much so. Patients with factor V Leiden, which has a single amino acid change, a glutamine residue in place of an arginine at position 506, have a significantly increased risk of venous thrombotic disease.
Why? What does that change do?
This condition, also termed APC resistance, arises because this mutated factor V Leiden is resistant to inactivation by APC. APC just can't cut it effectively,
So factor V hangs around for longer.
leading to prolonged procoagulant activity and thus an increased tendency to clot. It's a subtle change with a major impact on thrombosis risk.
If we connect this to the bigger picture, these elaborate inhibitory mechanisms, antithrombin, TFPI, protein CS, are not merely safeguards. They are integral components of the normal physiological state,
Absolutely. They're always active to some degree.
constantly ensuring that clot formation is both efficient when needed and precisely contained when its job is done. It's a continuous dynamic negotiation within your bloodstream, a constant push and pull.
Absolutely. The body isn't just forming clots, it's constantly regulating them through multiple redundant systems. This highlights the exquisite complexity and the numerous checkpoints built into the system to prevent both excessive bleeding and excessive clotting. It's true mastery of biological control, essential for survival.
Building on our understanding of these natural inhibitors, we now turn to how modern medicine leverages these pathways to prevent and treat thrombotic conditions. Let's talk about pharmacological anticoagulants, the blood thinners.
Right. One of the oldest and most widely used classes are the coumarin anticoagulants, with warfarin being the classic example. These drugs are orally administered and are incredibly effective for long-term treatment.
Warfarin, how do they work at a molecular level? What part of the clotting cascade do they target? It's related to vitamin K, isn't it?
Exactly. Coumarin drugs, like warfarin, inhibit the crucial vitamin K-dependent carboxylation of specific glutamate residues to GLA residues.
Those law residues again?
We keep coming back to them. This critical post-translational modification occurs in the amino-terminal regions of factors 2, prothrombin, sebum, NIX, and X, as well as proteins C and S.
So it hits both pro-clotting and anti-clotting factors.
It does, but the net effect is anticoagulant, because the pro-clotting factors are generally more affected or have shorter half-lives initially.
And why are those GLA residues so important again for these clotting factors? Remind us.
These GLA-containing proteins, all synthesized in the liver, absolutely depend on the calcium-binding properties of their GLA residues for their normal function in the coagulation pathways. Without proper carboxylation, they cannot effectively participate in the clotting cascade. They simply can't bind to the necessary phospholipid surfaces on platelets.
So warfarin stops them from becoming fully functional. How?
Coumarins specifically inhibit the enzyme that recycles vitamin K, the enzyme called vitamin K epoxide reductase. They reduce the quinone derivatives of vitamin K back to their active hydroquinone forms. Warfarin blocks this recycling.
Ah, so it traps vitamin K in an inactive state.
Essentially, yes, thus preventing the carboxylation step. It's like turning off the key step and making these clotting factors functional.
So if someone is on warfarin, can you reverse its effect if, say, they start bleeding too much? Can you give vitamin K?
Yes. The administration of vitamin K can bypass the coumarin-induced inhibition and allow carboxylation to occur, restoring the production of functional factors. Though reversal typically takes 12 to 24 hours, as new functional factors need to be synthesized by the liver.
Not instant, then.
Not instant. A faster reversal can be achieved by infusing normal coagulation factors directly, like prothrombin complex concentrates. This contrasts sharply with the almost instantaneous reversal of heparin by protamine, highlighting the different pharmacological approaches and timeframes.
And clinically, how are heparin and warfarin often used together in treatment? It seems like they have different roles and onsets. Why use both?
Okay, they are commonly used together in the initial treatment of thrombotic and thromboembolic conditions, such as deep vein thrombosis and pulmonary embolism, and for the long-term prevention of stroke in patients with heart rhythm abnormalities like atrial fibrillation.
Why the overlap?
Heparin is often administered first due to its prompt onset of action. It works almost immediately via antithrombin, while warfarin takes several days to reach its full therapeutic effect as the old functional clotting factors clear out of the system and are replaced by the non-functional ones. This necessitates that initial overlap, usually for about 5 days.
And they both require close monitoring, don't they? Because getting the dose wrong can be dangerous. Bleeding risk.
Absolutely. Both drugs require close monitoring using appropriate coagulation tests. For example, prothrombin time, or PT, often reported as INR, for warfarin, and activated partial thromboplastin time, or APTT, for heparin. This is crucial due to the significant risk of producing hemorrhage if not carefully managed, as their effect is not well predictable by dosage alone. Every patient metabolizes them differently, and diet affects warfarin too.
Complex to manage. And what about the newer kids on the block, the new oral anticoagulants, or NOACs, sometimes called DOACs? Direct oral anticoagulants. They've really changed the game, haven't they?
They have, representing a significant advancement in anticoagulation therapy, building on decades of biochemical understanding. They include direct inhibitors of thrombin, like dabigatran,
Directly blocking thrombin.
or direct inhibitors of factor ZAG, such as rivaroxaban, apixaban, and edoxaban.
Directly blocking factor ZAG, more targeted.
Exactly. Much more targeted than warfarin.
What are their big advantages over warfarin for patients and clinicians? Why the excitement?
These drugs offer significant advantages, including more predictable effects based on the dose, which simplifies management significantly. And, crucially, some do not require routine laboratory monitoring.
No regular blood tests.
For many patients, no, which greatly simplifies patient life and reduces healthcare costs. Specific reversal agents, such as antibodies or decoy molecules, are either approved or in various stages of development for these drugs, offering an important safety net that wasn't always available initially.
So they're becoming safer, too.
Yes, the availability of reversal agents is key, and research is ongoing to evaluate agents that specifically target the intrinsic factors, like factor 11 or 12, as potential new antithrombotics, potentially offering anticoagulation with even less bleeding risk, pushing the boundaries of targeted therapy even further.
This highlights the continuous evolution of therapeutic strategies, moving from broader spectrum interventions like warfarin to increasingly targeted and safer medications, all built on an ever-deepening understanding of the underlying biochemistry.
It's an incredible testament to scientific progress.
It truly is. It's how foundational biological research directly translates into improved patient outcomes and more precise medicine, saving and improving countless lives.
Couldn't agree more.
As we've discussed, the coagulation system is normally in a state of dynamic equilibrium, where fibrin clots are constantly being laid down and then dissolved. This latter process, the dissolution of clots, is termed fibrinolysis.
Breaking down the fibrin.
So we've built the fortress. Now, how does the body send in the demolition crew to break down these clots when they're no longer needed, or if they formed pathologically?
The primary enzyme responsible for degrading fibrin and fibrinogen, essentially the chief of the demolition crew, is plasmin.
Plasmin.
Plasmin circulates in the form of its inactive precursor, its dormant state, called plasminogen. It's made in the liver and floats around waiting.
And how is plasmin kept in check when it's just floating around, not needed, to prevent it from dissolving everything in sight?
Good question. Any small amounts of plasmin that are formed in the fluid phase under physiological conditions are rapidly inactivated by the fast-acting plasmin inhibitor, a 2-antiplasmin.
Alpha-2 antiplasmin, the plasmin neutralizer.
This is a crucial safety mechanism, like a chemical fire extinguisher, to prevent generalized breakdown of clotting factors and fibrinogen.
Yeah.
However, and this is the clever part,
Yes.
plasminogen binds to fibrin. It has specific binding sites, so it becomes incorporated directly into clots as they are produced.
It gets trapped inside the clot structure.
Exactly. Crucially, plasmin that is formed while bound to fibrin is protected from inactivation by a G2 antiplasmin.
Ah, the inhibitor can't get to it easily inside the clot.
Right. This allows it to remain active precisely within the clot where it's needed and only there. Very localized action.
So it's activated, then protected inside the clot. It's like a targeted missile, only active when it hits its target. And how is plasminogen activated? What turns it into plasmin?
Activators of plasminogen of various types are found in most body tissues. All of these activators make the same specific cut in plasminogen at an arg-val bond to produce the active disulfide bridge-linked 2-chain serine protease, plasmin.
And its specificity helps too.
Yes, the specificity of plasmin for fibrin is another key mechanism to regulate fibrinolysis. Through specialized protein regions called Kringle domains, plasmin or plasminogen specifically binds to lysine residues on fibrin.
Binds to lysine on fibrin.
This strong binding allows it to be increasingly incorporated into the fibrin mesh as it cleaves it, making it more efficient within the clot. It keeps chewing away from the inside.
And there's also an inhibitor that works by affecting those lysine residues, isn't there? Almost like a countermeasure to plasmin's targeting. slowing it down.
Yes, the enzyme called thrombin activatable fibrinolysis inhibitor, or T5I.
Activated by thrombin.
Yes, once activated by thrombin to tafia, it inhibits fibrinolysis by literally removing terminal lysines from fibrin. By doing this, it prevents plasmin's critical binding sites from being available.
So thrombin, which helps form the clot, also helps protect it from being broken down too quickly.
Exactly. It's another feedback loop. Thrombin activates TAFI to tafia, thus inhibiting fibrinolysis during clot formation, a very clever mechanism to ensure the clot is not prematurely dissolved before its job is fully done.
What are the key plasminogen activators, the ones that essentially trigger plasmin's activity, starting the demolition?
The most prominent and the one most relevant clinically is tissue plasminogen activator, or TPA.
TPA, where does that come from?
It's a serine protease released into the circulation from vascular endothelial cells under conditions of injury or stress. Importantly, it is catalytically inactive unless it is bound to fibrin.
So it only acts where there's a clot, and specifically where there's fibrin. It needs the clot to turn on.
Precisely. Highly clot specific. On binding to fibrin, TPA cleaves plasminogen within the clot to generate plasmin. Plasmin, in turn, digests the fibrin to form soluble degradation products, literally dissolving the clot away.
And then what happens to TPA and plasmin?
Neither plasmin nor the plasminogen activator can remain bound to these degradation products, so they released into the fluid phase, where they are then quickly inactivated by their natural inhibitors, like toplizin and PAI and plasminogen activator inhibitor 1. This prevents any unwanted systemic effects.
Very targeted and self-limiting. And a second activator, not as commonly used therapeutically, urokinase.
The precursor of a second activator is prurokinase, which converts to urokinase. Originally isolated from urine, it's now known that urokinase is synthesized by various cell types, including monocytes, macrophages, fibroblasts, and epithelial cells.
What's its main job?
The main action of urokinase appears to be the degradation of the extracellular matrix, playing a broader role in tissue remodeling beyond just intravascular clots, though it can activate plasminogen as well.
Now, these powerful agents, especially TPA, are used clinically as clot busters, aren't they? Truly revolutionizing emergency medicine for heart attack and stroke.
They are, and they've revolutionized the treatment of acute thrombotic conditions. Recombinant TPA, marketed as alteplase, is produced by recombinant DNA methods and is widely used clinically as a fibrinolytic agent.
And it's selective.
It is far more selective than older agents like streptokinase, primarily activating plasminogen that is bound to a fibrin clot, making it a highly targeted therapy with generally less bleeding risk.
And its clinical impact is massive for conditions like heart attacks and strokes. Time is critical, though, right?
Enormous impact. And yes, time is brain, time is muscle. If administered early enough, ideally within a few hours, the window varies depending on the condition, but let's say roughly within 6 hours after the onset of thrombosis, before irreversible damage occurs, TPA can significantly reduce the mortality rate and disability from myocardial damage following coronary thrombosis or from ischemic stroke.
So it saves lives and function.
Literally buys time and saves tissue. It's also used in the treatment of ischemic stroke, peripheral arterial occlusion, deep vein thrombosis, and pulmonary embolism in certain situations.
And what about streptokinase, the bacterial enzyme? Why is it less favored now?
Streptokinase is an enzyme secreted by certain streptococcal bacterial strains. Its main disadvantage is that it is less selective than TPA.
How so?
It activates plasminogen in the fluid phase, as well as plasminogen bound to fibrin. This fluid phase activation can lead to the widespread degradation of circulating fibrinogen, a state called systemic lysis, potentially causing dangerous bleeding.
Higher bleeding risk.
Yes, especially if the amount of plasmin produced by therapeutic doses exceeds the capacity of circulating additive antiplasmin. It also has the disadvantage of being antigenic.
Your body reacts to it.
Right. The body can develop antibodies against it because it's a foreign protein, making it less effective with repeated use and potentially causing allergic reactions.
And to stop fibrinolysis, if a patient is bleeding, maybe after surgery or trauma, is there a drug for that to prevent clot breakdown?
Yes. Tranexamic acid and imidacloprolic acid are lysine analogs. They act as inhibitors of plasmin activity.
How do they work?
They bind to the lysine binding sites on plasminogen and plasmin, preventing them from binding to fibrin. This effectively stabilizes existing clots and allows them to persist longer, helping to stop bleeding.
Finally, what disorders can affect fibrinolysis itself, throwing off this delicate balance? Can it go too fast or too slow?
Both. We can see increased plasminogen activators in disorders such as certain cancers and sepsis, which can potentially lead to excessive bleeding, due to overactive clot breakdown.
Clots dissolve too quickly.
Conversely, the antiplasmin activities contributed by IL-1 antitrypsin and I2 antiplasmin may be impaired in diseases such as severe liver disease, like cirrhosis, leading to a tendency to bleed. And as an interesting note, certain bacterial proteins, like streptokinase, naturally produced during infections, are capable of activating plasminogen, which may be responsible for the diffuse hemorrhage sometimes observed in patients with disseminated bacterial infections.
So many ways this balance can be disrupted.
It's a stark reminder of how external factors and internal diseases can disrupt this delicate, vital balance.
This raises an important question. What happens when there's a genetic flaw in this meticulously balanced system? Inherited deficiencies of the clotting system can lead to severe bleeding disorders, profoundly impacting an individual's life and offering unique insights into the system's normal function.
Indeed. Studying these deficiencies has taught us so much. The most common severe inherited bleeding disorder is hemophilia A.
Hemophilia A
Caused by a deficiency of factor VIII. Being an X chromosome-linked disease, it almost exclusively affects males. Females are typically carriers.
And hemophilia B, is that also X-linked? Different factor.
Yes. Hemophilia B is also an X chromosome-linked disease, but it's due to a deficiency of factor IX.
Factor IX, the intrinsic pathway again.
Exactly. This form of hemophilia holds historical significance as it famously played a major role in the royal families of Europe, passed down through generations via Queen Victoria's descendants.
Do they look the same clinically?
While their clinical features are almost identical, leading to prolonged bleeding after injury or surgery, and spontaneous bleeding, especially into joints and muscles, hemophilia A and B can be readily distinguished by specific laboratory assays that measure the levels of the two factors, factor VIII and factor IX.
What do we know about the genetic basis of these conditions at the level of the genes themselves, understanding the root cause?
The gene for human factor VIII, F8, is one of the largest known human genes, spanning a massive 186 kilobases in length and containing 26 exons that encode a protein of 2,332 amino acids. It's huge.
Complex gene.
The gene for human factor IX, F9, is much smaller, at 33 kilobases in length, containing 8 exons that encode a protein of 415 amino acids. A wide variety of genetic variants have been detected in both F8 and F9.
Mutations.
Yes, including partial gene deletions, point mutations causing amino acid changes, nonsense mutations stopping protein production, and missense variants, all leading to diminished activities of the respective factor proteins. The type of mutation often correlates with the severity of the disease.
Can we test for these?
Absolutely. These advancements in genetic testing now allow for precise carrier detection and prenatal diagnosis by DNA analysis after chorionic villus sampling or amniocentesis, offering crucial information to families.
It's remarkable how far treatment for hemophilia has come, transforming it from a devastating, often fatal condition into something manageable, almost miraculous. What was it like before?
It's a true testament to scientific progress in understanding this biochemistry. In the 1960s, treatment consisted initially of intravenous administration of cryoprecipitate.
What's that?
It's a fraction of plasma, enriched in factor VIII, prepared from individual blood donors. This was a step forward, but supplies were limited, dosing was imprecise, and it still carried risks of infection transmission.
Then came concentrates.
By the 1970s, lyophilized, freeze-dried, factor VIII or factor IX concentrates, prepared from very large plasma pools, became available. This significantly improved treatment, making it more accessible and consistent, allowing for home therapy. However, the large pools tragically led to widespread transmission of viruses like HIV and hepatitis C in the 1980s.
A dark period. And then came the big breakthrough with recombinant technology, eliminating the risk of blood-borne diseases. That must have been huge.
Absolutely game-changing. In the 1990s, a major breakthrough occurred with the introduction of factors VIII and IX prepared by recombinant DNA technology.
Made in labs, not from blood.
Exactly. These preparations were a game-changer because they're free of contaminating human viruses, thus dramatically improving patient safety. While initially expensive, their use is increasing as production costs decrease and access expands. They became the standard of care.
And what's available now, and what does the future hold for hemophilia treatment? Even better options.
Yes, progress continues. Currently, longer-acting recombinant factors with extended half-lives in the circulation are in use.
Meaning fewer injections.
Exactly, reducing the frequency of infusions for patients, sometimes from multiple times a week to once a week or even less. That's a huge quality of life improvement. For hemophilia A, there's even a novel non-factor replacement therapy administered subcutaneously.
Under the skin, not Phe.
Right. It's a bispecific antibody called emicizumab. It targets factor X and factor IgOs. This antibody cleverly brings these two proteins together in a way that mimics the function of factor VIII, effectively bypassing the need for factor VIII altogether.
Wow, a completely different approach.
And, excitingly, gene therapy for hemophilia is currently in late-phase clinical investigations, and some forms are even approved in certain regions,
Gene therapy, a potential cure.
offering the potential for a long-term, possibly lifelong, cure or near cure for these conditions by providing the patient's own body the ability to produce the missing factor. A truly revolutionary prospect.
That's truly life-changing for so many. Beyond hemophilia, what's the most common hereditary bleeding disorder affecting even more people, though often less severe?
That would be von Willebrand disease. Its prevalence is estimated up to 1% of the population, making it the most common inherited bleeding disorder, though many cases are mild.
And what's the cause? Deficiency in VWF.
It results from a deficiency or defect in von Willebrand factor, or VWF.
And we mentioned VWF earlier in platelet adhesion and aggregation, acting like a bridge or glue. What are its dual critical roles that, when deficient, lead to bleeding?
VWF is a large multimeric glycoprotein secreted by endothelial cells and platelets into the plasma. It plays two critical roles. First, it stabilizes factor VIII in the plasma, protecting it from premature degradation.
So low VWF can mean low factor VIII, too.
Yes, it can lead to a secondary deficiency in factor VIII activity. And second, VWF promotes platelet adhesion at sites of vessel wall injury and facilitates platelet aggregation, especially under conditions of high shear stress found in small vessels.
So it affects both platelets and factor VIII.
Right. It truly is the molecular glue for platelets and a chaperone for factor VIII. These genetic disorders, hemophilia and von Willebrand disease, underscore the profound impact of single protein deficiencies on the entire complex cascade, and how scientific understanding, built molecule by molecule, has led to remarkable and life-changing therapies.
For elite professionals in this field, whether you're a clinician, a researcher, or just someone who wants to deeply understand the system, diagnosis and monitoring rely on a battery of specialized laboratory tests.
Absolutely essential tools.
They measure various phases of the hemostatic system. What are some of these key diagnostic and monitoring tools that allow us to peek inside this complex dance? How do we measure this stuff?
They're absolutely essential for guiding clinical decisions and achieving mastery of patient management. First, we have a platelet count, which simply quantifies the number of platelets in a given volume of blood. Basic, but crucial.
How many workers are there?
Exactly. Then there's the bleeding time or closure time. The skin bleeding time is an older general test of platelet and vessel wall function, not used as much now. The closure time, measured using instruments like the Platelet Function Analyzer PFA 100-200, is an in vitro test that specifically assesses platelet-related hemostasis under high shear conditions, mimicking arterial flow.
Testing platelet plug formation under stress.
Right.
And to assess how well platelets are actually working, not just how many there are, their function.
That's where platelet aggregation tests come in. This test measures how platelets clump together in response to specific aggregating agents, such as ADP or collagen or thrombin, to assess their function directly in the lab.
Okay. Moving on to the coagulation pathways, the cascades.
We use the activated partial thromboplastin time, or APTT, sometimes just PTT. This is a measure primarily of the intrinsic pathway and common pathways of coagulation.
Intrinsic.
And it is notably used to monitor unfractionated heparin therapy. If you're on a heparin drip, this is your key test, done frequently.
And for the extrinsic pathway, that initial trigger, and warfarin.
For that, we use the prothrombin time, or PTT. This test is a measure primarily of the extrinsic pathway and common pathway. It is the standard test used to measure the effectiveness of warfarin therapy, usually reported as the INR, International Normalized Ratio.
TT-INR for warfarin, APTT for heparin.
Got it.
What about assessing fibrinogen directly, the raw material for the clot?
We have the thrombin time, or TT, which measures the time it takes for clot to form after purified thrombin is added to plasma. It directly assesses the quantity and function of fibrinogen, as that's thrombin's direct target.
Okay.
We also directly measure the concentration of fibrinogen to quantify the amount of this key clotting protein in the plasma using immunological or clotting-based assays.
And for clot strength, how stable that fibrin mesh is, the cross-linking.
Fibrin clot stability tests assess the strength and integrity of the formed fibrin clot, often by seeing if it dissolves in certain solutions. This is often related to factor 13 activity, that cross-linking enzyme. A clot that breaks down easily suggests a factor 13 deficiency.
And finally, measuring clot breakdown, fibrinolysis.
Finally, we have the measurement of fibrin degradation products, or FDPs, or more specifically, D-dimer. D-dimer is a specific fragment produced only when cross-linked fibrin is broken down by plasmin. Detecting these indicates that clots have formed and are being broken down.
So high D-dimer means recent clotting and lysis.
Exactly. It's used clinically to help rule out conditions like DVT or pulmonary embolism.
What stands out to you about these tests? Why are they so critical for truly understanding your own body's clotting system and for a clinician's ability to intervene effectively, for achieving that mastery?
These tests are the essential tools that allow clinicians to pinpoint specific issues within your clotting system. Is it a problem with platelets? Which coagulation pathway is slow? Is fibrinolysis overactive? They guide diagnosis, inform treatment decisions for bleeding or clotting, and ensure the safe and effective use of anticoagulant and antiplatelet medications by monitoring their effects.
Indispensable.
Absolutely. Without them, managing these incredibly complex conditions would be largely guesswork. They allow us to precisely understand the dynamic balance in an individual patient, helping us master the nuances of each person's unique physiology and tailor treatment accordingly.
And with that, we've truly embarked on a deep dive into the astonishing world of hemostasis and thrombosis. It's incredibly intricate.
It really is.
From the immediate seal of a platelet plug to the intricate cascade of zymogen activations and the crucial counterbalance of fibrinolysis, it's clear that your body performs a constant dynamic ballet of biochemical processes every single second of every single day.
We've seen how platelets are not just passive players, but active orchestrators, with their complex adhesion, release, and aggregation mechanisms, driven by intricate outside-in and inside-out molecular signaling. It's a testament to microscale intelligence and coordination.
We've mapped out the two major coagulation pathways, extrinsic and intrinsic, understanding how they converge to form the stable fibrin clot, a process requiring precise activation and inactivation of many factors, each playing its vital, interconnected role. The complexity is astounding.
And we explored the body's elegant built-in anticoagulant mechanisms, from antithrombin and TFPI to the protein CS system that relentlessly work to prevent runaway clotting and maintain the vital fluidity of your blood. Those controls are just as important as the clotting itself.
And we learned how the fibrinolytic system, led by plasmin and activators like TPA, ensures that clots are dissolved once their job is done, or when they become dangerous, highlighting the continuous cycle of building and breaking down, always seeking balance.
Finally, we touched on how genetic defects can lead to serious bleeding disorders like haemophilia and von Willebrand disease, but also how our ever-deepening scientific understanding has led to remarkable and truly life-changing therapeutic breakthroughs, turning previously fatal conditions into manageable ones. The progress there is just incredible.
So what does this all mean for you? The next time you experience a minor cut or simply reflect on the constant silent flow of blood within your veins, maybe take a second to consider the profound complexity and precision of this biological system.
A little appreciation for the biochemistry.
This intricate dance, constantly balancing clot formation and dissolution, is a testament to the marvels of human biology. It's a reminder that even the most seemingly simple bodily functions are governed by a symphony of molecular interactions, operating at a level of sophistication that continues to inspire awe and curiosity.
Absolutely.
What further secrets might this system hold, and what future breakthroughs will continue to redefine our understanding of health and disease as we strive to master this information like the elite professionals in the field?
We hope this deep dive has given you a solid foundation for that mastery, a framework to build upon, and perhaps sparked even more curiosity to keep learning about this vital system.